I want you to think about last night. Specifically, I want you to think about your legs. Were they heavy when you went to bed? Were they aching in a way that felt different from muscle soreness? Did you feel a restless, crawling, almost electric discomfort that made it impossible to lie still? Did you wake up with a cramp so sharp it took your breath away? A cramp that gripped your calf like a fist and refused to let go? Or did you notice that your legs felt cold or that one foot looked slightly different in color from the other? Every one of those sensations has a name, and every one of them is your cardiovascular system trying to get your attention in the only language it knows how to speak. My name is Dr. James Mercer. I am a board certified physician with 35 years of clinical practice and over 40,000 patients treated. I have spent decades in examination rooms listening to patients describe sensations in their legs that they had been chalking up to age, to overdoing it in the garden, to needing a new mattress. And in too many of those cases, what was actually happening was something far more serious than any of those explanations could account for. Today, I'm going to walk you through exactly what your legs are trying to tell you at night, what each specific sensation means, which ones require a phone call to your doctor this week, and what you can do right now, starting tonight, to begin protecting the cardiovascular system those sensations are warning you about. Pay close attention, because this information could genuinely save your life. Let me start by explaining something that connects your legs and your heart in a way that most people over 60 have never been clearly told. Your legs are not separate from your cardiovascular system. They are part of it. The same network of arteries that carries oxygenated blood from your heart to your brain, your kidneys, and your vital organs also carries it all the way down to your thighs, your calves, your feet, and your toes. And the same disease process that silently narrows the coronary arteries supplying your heart muscle and the carotid arteries supplying your brain is the very same process that narrows the arteries of your legs. That disease process is called atherosclerosis, and it is the foundational cardiovascular threat of aging. Atherosclerosis begins with inflammation of the endothelium, the delicate single-cell lining of every artery in your body. Over years and decades, LDL cholesterol particles infiltrate and become oxidized in the arterial wall. The immune system responds. Foam cells form. Plaques develop. Those plaques grow, harden, narrow the arterial channel, and reduce the flow of blood to every tissue downstream of the blockage. In the coronary arteries, the result is angina or heart attack. In the carotid arteries, the result is stroke. In the arteries of the legs, and the result is a condition called peripheral artery disease. And peripheral artery disease is one of the most underdiagnosed, undertreated, and consequential cardiovascular conditions in the entire senior population. Here is the number that should make every person over 60 stop and pay attention. The prevalence of measurably reduced blood flow in the legs, as determined by a simple test called the ankle brachial index, is approximately 8% in adults aged 60 to 74. It rises to 17.5% in adults aged 75 and older. Among seniors with diabetes, hypertension, a history of smoking, or elevated cholesterol, the prevalence is significantly higher, approaching 30% in high-risk groups. The American Heart Association estimates that at least 12 million Americans over 40 have peripheral artery disease. And because more than half of all people with PAD have no classic symptoms, or have symptoms they dismiss as normal aging, the majority of them have no idea. That is the crisis I am here to address, because the leg sensations you are about to hear described are the body's early warning system, and the body is a remarkably persistent communicator when you know how to listen. Let me walk you through the specific nighttime leg sensations that carry cardiovascular significance, and I want you to listen carefully, because some of these are conditions most doctors never connect to heart health in the conversations they have with their patients. The first sensation is the classic cramping pain that starts when you walk and disappears when you stop. If you have noticed that walking a certain distance, a block, half a block from the parking lot to the grocery store, consistently produces a deep, aching, burning, or cramping pain in your calf, your thigh, or your hip. and that pain reliably goes away within a few minutes of stopping and resting. I need you to hear this clearly. That pattern has a name in medicine. It is called intermittent claudication, and it is the hallmark symptom of peripheral artery disease. Here is the exact biology of what is happening. When you walk, your leg muscles demand more blood. In healthy arteries, the vessels dilate to accommodate that increased demand. In arteries narrowed by atherosclerotic plaque, the vessels cannot dilate adequately. The blood supply falls short of what the muscles need. The muscles enter a state of oxygen debt. They produce lactic acid and other metabolic waste products that cannot be cleared fast enough. The result is that familiar deep cramping ache. When you stop walking, the muscle's demand drops. The narrowed artery is able to supply enough blood for rest conditions. The waste products clear and the pain resolves. This stop and go pattern, pain with walking, relief with rest, is so characteristic of PAD that a vascular specialist can often make the clinical diagnosis from this description alone before any testing. And what that diagnosis tells me is not simply that there is a plaque in the artery of your leg. It tells me that your entire cardiovascular system, your coronary arteries, your carotid arteries, your renal arteries, is operating in an atherosclerotic environment. People with PAD have dramatically elevated rates of heart attack and stroke. In my 35 years of practice, I have never seen a patient with confirmed peripheral artery disease who did not need a thorough cardiovascular evaluation. Never. The second sensation is one that most people describe simply as cold feet, but I am not talking about cold feet on a chilly evening that warm up with socks and blankets. I am talking about feet and lower legs that feel persistently colder than the rest of the body, that do not warm up readily, that sometimes look pale or have a slight bluish or purplish discoloration, particularly in the toes. This is called poor peripheral perfusion, and it means that the circulation reaching the distal extremities, the feet and toes that are farthest from the heart, is impaired. Here is how to check this right now. Look at your feet, both of them. Compare the color of the skin between the 2 feet. Is one noticeably paler than the other? Now press firmly on the tip of a toe with your thumb and hold for 3 seconds. Release. The color should return to normal pink within about 2 seconds. If it takes longer than that, if the color returns slowly or incompletely, the capillary refill time is prolonged. That is a clinical sign of reduced arterial perfusion to the tissue. Now try this. Lie on your back and raise both legs to a 45-degree angle. Hold for 60 seconds. In a person with healthy leg circulation, the legs will remain pink throughout this elevation. In a person with significant PAD, one or both legs will become notably pale or even white during elevation because the narrowed arteries cannot generate enough pressure to push blood uphill to the elevated extremity. This is called the Buerger test, and it is a bedside clinical assessment that vascular specialists perform in office. You can perform it at home tonight. If your leg or foot becomes pale when elevated and then develops a dusky red color when lowered back down, called dependent rubor, that color change pattern is a reliable sign of significant circulatory impairment that warrants immediate evaluation. The third nighttime leg sensation I need you to understand is rest pain, and this one is urgent. Rest pain is exactly what it sounds like. Pain in the foot or lower leg that occurs at rest, particularly at night when you are lying in bed. It is a burning, aching, sometimes excruciating pain typically felt in the foot and toes. It is frequently so severe that patients hang their foot off the edge of the bed or get up to stand because the act of lowering the foot below the level of the heart uses gravity to passively increase blood flow to the foot, just enough to provide temporary relief. If you are hanging your foot off the bed at night to relieve leg pain, that is not a quirky sleeping habit. That is a compensatory behavior for a limb that is not receiving adequate arterial blood flow even at rest. In vascular medicine, rest pain is classified as critical limb ischemia, a serious and advanced stage of peripheral artery disease where the tissue is in danger. Rest pain means the arterial blockage has progressed to a point where the blood supply is insufficient even under basal conditions. Without intervention, the tissue distal to that blockage begins to suffer. Wounds that do not heal, ulcers that progress rather than resolve. In the most severe cases, tissue death, gangrene, amputation. I am not describing this to frighten you. I am describing it because rest pain is a medical emergency that is walking into primary care offices across this country and being sent home with an NSAID prescription. If you or someone you love has leg or foot pain at rest that worsens at night and improves when the foot is lowered, that person needs a vascular evaluation this week, not next month. This week, the fourth sensation is the one that carries the most surprising cardiovascular implication, and it is one that millions of seniors experience every night without any idea of its significance. Restless legs, that irresistible urge to move the legs that comes on in the evening or at night, the crawling, tingling, pulling, itching feeling deep inside the leg tissue that is not quite pain but is completely incompatible with stillness. The sensation that temporarily improves when you walk, stretch, or move the leg, and returns immediately when you lie back down. This is called restless leg syndrome, or RLS. And for decades, it was treated as a sleep disorder and nothing more. Here is what the research published in the American Heart Association's journal Circulation Research in 2025 now makes clear. Restless leg syndrome is associated with measurably elevated cardiovascular risk. A landmark study found that people with RLS were more than twice as likely to have cardiovascular disease or cerebrovascular disease compared to people without RLS. The association was strongest in people whose RLS symptoms occurred at least 16 times per month. Research published in the Journal of the American Heart Association found that treating RLS was associated with a lower risk of cardiovascular disease over a follow-up period of 3.4 years. The biological mechanisms connecting RLS and heart disease are now being actively studied, and the leading theory involves the periodic leg movements that accompany RLS during sleep. Those involuntary leg movements, which can occur 200 to 300 times per night in severe cases, each trigger a brief but sharp spike in blood pressure and heart rate as the sympathetic nervous system activates. Over months and years of nightly repetition, that pattern of nocturnal blood pressure surges may contribute to the accelerated development of cardiovascular disease in exactly the same way that untreated hypertension does. This connection between the crawling restlessness in your legs at night and the health of your cardiovascular system is one of the most important and least communicated findings in recent cardiovascular medicine. And the people who most need to hear it are the ones who have been living with restless legs for years, being told to take magnesium and stretch before bed, with no one connecting the dots to the heart. Now, let me tell you what you can do. Starting right now, starting with information that your body and your physician both need. Step one is the most important thing I can ask you to do in the next 7 days. Request an ankle brachial index test. This is one of the simplest, most informative, most painless vascular assessments available in medicine. It takes about 10 minutes. A cuff is placed on your arm and on your ankle. Blood pressure is measured at both locations. The ratio of the ankle pressure to the arm pressure gives a number called the ankle brachial index, or ABI. In a person with healthy leg circulation, the pressure at the ankle is equal to or slightly higher than the pressure at the arm, giving an ABI of 1.0 or above. When the arteries of the leg are narrowed by plaque, the pressure downstream of the blockage falls. An ABI below 0.9 is diagnostic of peripheral artery disease. An ABI below 0.5 indicates severe disease requiring urgent vascular intervention. This test is available at most primary care offices, cardiology offices, and vascular clinics. Most insurance covers it in patients over 50 with cardiovascular risk factors, and it gives your physician an objective measure of your arterial circulation that cannot be determined from history or physical examination alone. If you have any of the symptoms I described, claudication, cold feet, rest pain, restless legs, or any history of cardiovascular disease or diabetes, this test is not optional. It is essential. Go to your next appointment and say 4 words, "I want an ABI." Step 2 is a lifestyle intervention that has more clinical evidence behind it for peripheral artery disease than any medication I can prescribe. Supervised walking therapy. I know this sounds counterintuitive. If your legs hurt when you walk, the last thing you want to hear is to walk more. But here is the biology. When arteries are narrowed by plaque, the body has a remarkable compensatory mechanism available to it called collateral circulation. Collateral vessels are smaller, accessory blood vessels that can be recruited to carry additional blood flow around a blockage, if the tissue is given a sufficient stimulus to develop them. The stimulus for collateral vessel development is precisely the ischemic stress that occurs during exercise, walking to the point of claudication pain, resting, and walking again, repeated daily, sends the signal to the vascular biology of the leg that more supply pathways are needed. Over weeks and months, new collateral vessels form. Pain-free walking distance increases. Functional capacity improves. The updated 2024 ACC and AHA guidelines for the management of lower extremity peripheral artery disease specifically recommend structured exercise therapy as a first-line treatment for claudication, not as an afterthought, not as something to try alongside medications, as a primary evidence-based intervention, a 20 to 30-minute daily walk at a pace that brings on mild claudication symptoms, followed by rest until the pain subsides, followed by continued walking, is more effective at improving walking distance and quality of life in PAD than most pharmaceutical interventions. Step 3 is dietary, and here I want to connect directly to the atherosclerosis that is causing the leg symptoms in the first place, because peripheral artery disease is not a leg problem. It is a systemic arterial disease that is expressing itself most noticeably in the legs. The same dietary changes that protect the coronary arteries protect the leg arteries. Every intervention that slows atherosclerotic progression elsewhere in the body slows it in the legs as well. Remove refined seed oils from your kitchen entirely. Canola oil, soybean oil, corn oil, vegetable oil. These are loaded with omega-6 fatty acids that drive the oxidative and inflammatory environment in which LDL cholesterol becomes dangerous. Replace them with extra virgin olive oil. The oleocanthal in extra virgin olive oil inhibits the same inflammatory enzymes that anti-inflammatory drugs target. Add wild-caught fatty fish 3 times per week. The omega-3 EPA and DHA in fatty fish reduce triglycerides, lower inflammatory markers, and improve endothelial function, the function of the arterial lining that peripheral artery disease compromises. Add daily garlic. Garlic contains allicin, a compound with documented antiplatelet activity that reduces the tendency of blood to clot on the rough surface of arterial plaques. In clinical studies, garlic supplementation has been associated with modest reductions in plaque progression and improvements in claudication distance. Step 4 addresses restless leg syndrome specifically, and this is where the research points to one of the most treatable nutritional deficiencies in the senior population. Iron deficiency, even without frank anemia, is strongly associated with restless leg syndrome. The dopaminergic neurons in the brain that regulate the leg movement compulsion in RLS require iron for their function. When brain iron stores are low, dopamine signaling in these circuits becomes dysregulated. The result is the crawling, irresistible urge to move. Ask your doctor to check your serum ferritin level, not just your hemoglobin, but specifically ferritin, which is the storage form of iron. A ferritin level below 50 micrograms per liter is considered suboptimal for the treatment of RLS by most neurological sleep specialists, even if the level is technically within the broad normal range. If your ferritin is low normal, an iron-rich dietary approach, lean red meat 2 to 3 times per week, dark leafy greens, legumes, pumpkin seeds with vitamin C consumed alongside to enhance iron absorption can meaningfully improve ferritin levels over 2 to 3 months. In more significant cases, oral iron supplementation taken on alternate days, a regimen that research has shown optimizes absorption compared to daily dosing because the gut's iron transport mechanism has time to reset, is an effective approach that your physician can guide. Step 5 is magnesium. For nighttime leg cramps, the sharp, painful type that wake you from sleep and grip the calf muscle involuntarily. Magnesium glycinate taken each evening is the intervention I recommend most consistently. Leg cramps involve involuntary sustained muscle contraction, and magnesium is the physiological brake on muscle contraction throughout the body. Adequate magnesium allows the muscle to fully relax between contractions. When magnesium is deficient, which it is in the majority of American seniors consuming a standard Western diet, the muscle's ability to fully release is impaired, and the threshold for spontaneous cramping is lowered. 300 to 400 milligrams of magnesium glycinate taken 30 to 60 minutes before bed has eliminated nighttime calf cramps in more of my patients than I can count. It is the first recommendation I make, and in most cases, it is the only one needed. Step 6 is compression for the swelling, heaviness, and aching that develops in the legs throughout the day and worsens by evening. Graduated compression stockings are among the most effective and most underused interventions available to seniors. Compression stockings improve venous return from the legs, reduce the accumulation of interstitial fluid in the lower leg tissue, and improve the pumping efficiency of the calf muscle veins. They do not replace arterial circulation. They are specifically for the venous and lymphatic component of leg heaviness and swelling. A compression level of 15 to 20 millimeters of mercury is appropriate for most seniors without significant PAD. If you have confirmed peripheral artery disease, compression must be used with caution and under physician guidance because increasing external pressure on an already compromised circulation can in some cases worsen tissue perfusion. Now let me tell you what the system's financial structure has made it very difficult for most physicians to communicate to their patients over the past several decades. Peripheral artery disease and restless leg syndrome are both conditions where the pharmaceutical industry offers solutions. Cilostazol for claudication, ropinirole, and pramipexole for RLS. These medications work for some patients with real side effects, real costs, and real limitations. But the lifestyle interventions I just described, the structured walking therapy, the dietary changes, the iron optimization, the magnesium glycinate, these have evidence behind them that is as strong or stronger than the pharmacological alternatives for most patients at the mild to moderate disease stage, and they cost almost nothing. A patient who exercises daily, eats wild-caught fish 3 times a week, takes magnesium glycinate at night, optimizes their iron status, and gets an ABI test to know where they stand, is doing something more sophisticated and more comprehensive for their vascular health than most pharmaceutical protocols achieve. But there is no billing code for the evening walk. There is no prescription to write for the fish, and a 15-minute appointment cannot accommodate the explanation of why these things matter. That is why I am here. This is the conversation I want every patient over 60 to have, not after the heart attack, not after the limb-threatening event. Now let me walk you through 3 futures, and I want each one to feel real to you. In the first future, the symptoms I described tonight sound familiar. The cramping when you walk, the cold feet, the restlessness at night, but they have been there for months or years, and you have adapted to them. You have shortened your walking route. You have started sitting more. You have accepted the restless nights as your new normal. And because nothing dramatic has happened yet, nothing changes. The atherosclerosis progresses at its own quiet pace. The collateral circulation that exercise would have stimulated does not develop. The plaque in the leg arteries grows. The plaque in the coronary arteries grows alongside it. The cardiovascular event that all of this is building toward remains on the horizon, getting closer with each month that passes without intervention. In the second future, you take partial action. You mention the leg symptoms at your next appointment in passing. You make one dietary change. You try the magnesium for a few nights, but you do not request the ABI. You do not start the structured walking program. You do not address the iron. The partial approach yields partial results. The symptoms moderate slightly, but the underlying disease process continues unchecked because the full signal was never received and acted upon. In the third future, this week you call your doctor's office and request an ankle brachial index test. Tonight, you start the magnesium glycinate before bed. Tomorrow afternoon, you take a 20-minute walk, reaching mild claudication pain if present, resting, and continuing. This week, you replace the cooking oil with extra virgin olive oil and put salmon on the dinner menu. You ask your doctor to check your ferritin level at your next appointment. And within 4 weeks, you notice that the evening restlessness has eased. Within 8 weeks, the walking distance before cramping has increased. Within 12 weeks, you have objective data from a follow-up assessment telling you whether your vascular status has responded to what you are doing. That third future is built from decisions you can make today. None of them require a prescription. All of them require that you take what your legs are saying seriously enough to act. Here is my personal medical opinion, stated without qualification. The sensations your legs produce at night are not random. They are not incidental to the aging process. They are the most accessible, most available, most informative window into the health of your cardiovascular system that your body can offer you. Most people walk past that window every night on their way to the bathroom and never look through it. I am asking you to look through it tonight. What you see may change everything. Before you go, and I want to hear from you in the comments, which of the leg sensations I described tonight do you experience? The walking cramps, the cold feet, the restlessness, or the nighttime pain? Tell me which one resonates most. I read every comment, and your answers directly shape what I cover next. If this gave you something important today, hit subscribe right now, because every week I come back here with the honest cardiovascular information that seniors deserve and so rarely receive. Next week, I'm going to reveal a dangerous connection between one of the most commonly prescribed medications for people over 65 and a specific nighttime leg symptom that is almost never listed on the drug's warning label. You will not want to miss that one. I am Dr. James Mercer. Your legs have been speaking. Now you know the language. I will see you next week.